Afternoon. Thank you everyone for joining us for today's webinar on UKAS accreditation for physiological services. I'm going to hand over shortly to Laura Booth, who will be delivering the presentation. Laura's Senior Assessment Manager in the IQIPS team, so it's more than capable of taking you through this, looking at some of the changes in this process, and there will also be a Q&A session at the end as well. If you have questions, we're not enabling microphones or cameras in this session, but please do submit them into the chat section and we will get to them at the end of the webinar. So with that, I am going to hand over to Laura now. Thank you very much.
Yeah, thank you very much. So good afternoon, everyone. Thank you so much for taking the time to meet with us and to go through the IQIPS processes. I'm sure some of you are very familiar with. The focus on this is really very much a follow-up from the webinar that was delivered with NHS England back in December. So really looking at the focus of what's happened with particularly paediatric audiology services, but also to try and give an overview of not restraining that just to the audiology discipline, that we are opening up sort of the assessment processes to all of the diagnostic services. So we're really looking at trying to support all organisations as best we can from a UKAS perspective and from quality improvement and accreditation at early a stage as we possibly can. So I just want to give a quick overview for those of you who may not be as familiar with UKAS. We are the UK accreditation service. We are appointed by government, by Department of Business and Trade, as the sole accreditation body. So we are the only organisation that can offer independent accreditation activity. Originally, it was founded in 1966, but consolidated into UKAS in 1995. And we are a non-for-profit organisation. So that means that any of the profit made from UKAS assessments is ploughed back into the organisation and supports a lot of the development projects that we have within UKAS at the moment. The IQIPS scheme originally was a development project which started in 2012 and has since now moved into the operations section of the organisation. And it has become more of an operational process delivered against the international standard of accreditation, which is 17011 that we work to. So we have, as you can see, over 3,000 accreditations that are performed a year with a significant number of assessment days. We employ full-time staff, which consist of customer liaison officers, finance, HR, training teams, and then the core assessment staff within the organisation, so the assessment managers. So we've got over 200 assessment managers employed that are appointed to each customer that comes through for the accreditation process. The accreditation process itself is supported by over 700 external technical assessors. So we have external resource from all the different disciplines that are within the IQIPS standard. So as we know, audiology is predominantly one of the main organisations and services that come through at the moment with the IQIPS standard, but it also covers 7 other disciplines, including cardiac physiology, respiratory, vascular, etc. So some of you may be not just from audiology, but to just sort of make you aware that everything within UKAS is approached across those 8 disciplines and nationally as well. So we're looking at Wales and Scotland and Northern Ireland. So those technical assessors, they're involved, they might well be your peers. They go through a UKAS training process in how to become a technical assessor, but they are the technical experts around the clinical activity. So if we're looking at specifically, say, paediatric audiology, the technical clinical expertise comes from those experts that are professionally working in that practice and who are competent to do so. So historically, with IQIPS and with any UKAS assessment, we would expect an organisation who wishes to engage with accreditation to come forward when they feel they're ready to meet the standard. There are a variety of standards, obviously, that UKAS work towards. Within healthcare alone, we have ISO 15189 for medical laboratories. We have the British standard 70,000, which is used for medical physics and engineering and the imaging services. We've obviously got IQIPS. We also have QSI, which is also around imaging services. But across UKAS itself, we have many other sections, such as certification, inspection body, assessments, and a huge number of standards that we work towards. So just thinking about your everyday activity, a lot of what you do and what you're involved in, from your drinking water to the safety of the food that you're eating to the vehicles that you drive in, all of that is underpinned by accredited activity of the inspection bodies or the certification bodies in place. So we're very wary that, you know, the IQIPS scheme, as we say, covers audiology activity, and that's where we're assessing audiology and any of the other disciplines against the IQIPS standard. Now, the IQIPS standard itself, for those of you who may not be as familiar, it has currently 5 different domains. The first domain is the leadership and management domain, and that is focusing very much on the governance areas of your management system, of your organisation. And it's looking at areas of incidents, non-conformity management, audit processes, the roles and responsibilities, incident management, and looking at making sure that you've got those systems in place that you can actually evidence that you're following those systems and that they're effective. There's a patient experience domain, and as you can imagine, that's actually quite different from some of the other healthcare disciplines, particularly medical laboratories. Very few medical laboratory activities are patient-facing. So particularly for imaging and for physiological sciences, the patient experience domain is really important. And that focuses on patient-centred care. It looks at patient information, talks about patient consent, and then feedback from patients in both positive and complaints processes. There's a facilities, resource and workforce domain. So that's looking at the areas about whether you have got adequate accommodation or facilities and equipment to provide the services that you need, and also the resources with regards to staffing, which at the moment we do know is particularly challenging for audiology and for a lot of the other healthcare disciplines. There's also then the clinical domain. So this is where it differs across the particular disciplines. So that's where you're looking at clinical pathways. The standard goes through pathways from referral to discharge, and really trying to make sure that processes are streamlined, that the effectiveness of those systems in the outcomes of what you're delivering for the end result for those patients and for users longer term. So it's important there for commissioners, for patients, and for you to know that the outcomes you're getting are appropriate, safe and effective. And then we've got the safety section, which again covers risk management, health and safety, mandatory training, making sure that you've got all the capacity there to maintain a safe and effective service delivery. So we're very wary that normally an organisation would apply to us when they're ready for accreditation, but it is fully recognised, I think, over the last few years that not all services are at a point of being able to be anywhere near meeting the standard requirements for the IQIPS scheme. But there is a need to obviously engage in quality improvement and a desire to obviously try and improve and work on service provision, and also get the resources and backing from those people that you need support from, whether that's internally in your organisations or ICBs. And so what we've decided to do, and we launched last year, was look at a slightly different approach of trying to get organisations engaged with us in accreditation at a much earlier stage. And we've done this by offering this benchmarking assessment approach. So for that to happen, we still need organisations to apply to UKAS as a customer of UKAS, but then we can offer particular in-depth assessments or robust bespoke assessments depending on what area and what activity you want us to look at. The benefit of this is also that you are showing that you're starting to engage in the accreditation quality improvement process, because you've become an applicant and we're working with you to support you moving on your journey. And it shows the continued engagement with us in moving towards achieving that accreditation ultimately at the end of the day. So we've piloted this benchmarking approach. It started last year, and we've had 5 organisations go through this approach where they've applied to UKAS, and on discussion and off the back of some of the elements that have come out of the NHSE reviews, these services were wanting a full on-site assessment so that we could come and look at the quality management system that was in place at that time. We could have a very open and honest conversation with the staff. They were able to sort of support and go through their concerns with what was working and what wasn't working for them, and also observing technical practice. So we were able to really just benchmark, where are you, or where is the organisation at this point in time in meeting maybe the requirements of a safe, effective service against the standard. The benefits of this was that you don't have to have any documentation. You can be at any stage in your process. So we would ask to see some documents prior to an on-site assessment, but that can be as little or as much as you actually have accessible. And we have seen a huge variety of different documentation and limitations of what services have in their possession. So these benchmarking assessments, as I say, we've gone through 5 of those. One of those was a combined assessment. They wanted us to look at the adult service as well as the paediatric audiology service, and the other 4 were predominantly paediatric audiology. And we've looked at different locations, looked at their different facilities. Now, the different types of benchmarking we can offer, so as I've alluded to, these 5 ones that have gone through so far have been a full on-site assessment. So they've taken advantage of having a lead assessor and technical assessor resources physically coming in on-site and being able to see how their documentation works, reviewing what documentation they've got, identifying the gaps for them, and also the technical staff are then observing practice and seeing, is there anything that is of concern, or is there good practice? It's not all obviously about finding anything that's wrong with a service. It's also about highlighting the good practice. So the full on-site benchmarking has involved that sort of review, quality management system review, clinical observation, but also importantly, clinical record reviews. Because what we've learned in our accreditation process over the years is that actually direct observation of staff and patients on a specific day, you may well see the interaction and the service being delivered appropriately for that staff member, for that patient at that time, but it's only a sampling. So when we've looked through clinical records, that's when it's become maybe more obvious that things are not consistently being implemented, or documents and records are not necessarily being appropriately managed. And so actually the clinical record reviews have been extremely beneficial to supporting those on-site assessments and the whole management system review. So the benefit of that gives a real full coverage, and it's provided those services with a comprehensive report that highlights any significant key areas that need to be actioned with more immediate effect if there's any potential safety or harm to patients identified. It's also highlighted and really, I think, supported some of those services where they've been struggling to get backing for new resources, more staffing, equipment updates. And it's also maybe highlighted where there's been communication issues within the organisation or even within the service that has maybe limited training needs, requirements. So it's certainly given a robust review and significant actions for those services to then start moving forward. And we're at that point now where we're a year on from some of those assessments, and we're now looking to re-engage with them to be able to offer some more observation or more review of documentation so that we can see how are they progressing, because that's the important thing for services. And I think it's always been a bit of a problem in the past that services may have applied or been involved with accreditation but not actually shown progression, just been sitting there and not moving forward. So we want this to be a collaborative moving forward approach. Another approach that we can offer is purely remote to start with, so we can look at having a lead assessor and or technical assessor doing an assessment with you through Teams, so through this mechanism, and sharing documentation, looking at, again, matching the standard, looking at the management system so that we can identify gaps. We can do some clinical case records through that particular methodology. And if that then highlights any particular concerns through the clinical case reviews and record reviews that might mean that a direct observation of practice would be worth doing, we could then add that technical assessor on-site observation as an extra assessment. So that's that staged option, that third column there. And so therefore it doesn't add any further costs really to the overall on-site if you've gone for full on-site, but it gives you that staged approach of understanding where your gaps might be in your management system in the first instance, and then obviously capturing maybe a bit more of a wider view of that on-site activity. We've got a rough idea of costs here. For application to UKAS, the cost is £1,685 plus VAT, and that's a one-off cost. That is an application fee for the legal entity and the organisation. So if you decided at another stage that you were going to bring on some other activity, so you might start with paediatric audiology and then bring on, once you're accredited, the adult activity, or you might decide to work with cardiac, respiratory, vascular, and they want to come on as extensions to scope to accreditation, then there's no extra sort of costs there from an application perspective. But these give you just some rough ideas, and I'm very, very happy to sort of work with you if you want some estimates to put business cases together. I can do that, because obviously the cost very much depends on the locations that you wish to sort of look for accreditation for, and the amount of activity that you wish to go forward for. Some of the common themes from the pilot of these sort of benchmarking assessments we were finding, very common generally, is that literally the organisational management, leadership roles and responsibilities, either they weren't defined in the first place, or lots of the roles and responsibilities were not accountable. So from a clinical governance perspective, there were some key areas there that needed to be firmed up and have authority for, and enable that communication streamline. Training, internal, external, that was highlighted as an issue. So in some organisations, they've either had limited access to external training, and it's all been delivered internally, which, as we know, can sometimes breed sort of bad habits that come through from there. But certainly, you know, access and funding for training, so we can highlight that and we can sort of try and make that a priority where needed. The quality management system documentation. So I think a lot of organisations, you'll already have a lot of management system documentations. You'll have policies and procedures in place, maybe at a higher level for the organisation. But actually, when it comes to your service level documentation around clinical protocols, how you deliver your lower level infection control processes, things like that, a lot of that wasn't documented. And actually some organisations didn't even have necessarily the clinical protocols documented in any sort of robust format. So there's a big variety of what we see across really these assessments. Certainly, you know, discharge criteria, and I know from an audiology perspective, there's the guidance that's out for consultation at the moment to try and, again, get consistency and make sure people are appropriately implementing discharge criteria for those paediatric patients. Performance and KPIs and targets and capacity and demand, a big problem. And we know, we do acknowledge that at the moment, resources are really challenging to actually have enough staff, enough feet on the ground to deliver the capacity that you, and the demand that you have at the moment. And meeting targets, being able to meet waiting times is a real challenge. So again, this is something that we can highlight and try and push forward. And I know sometimes it's out of your control as managers. There may be freezes on staffing in an organisation, but again, the more we can highlight and push the impact on patient care, the more it can hopefully help you moving forward. Competency frameworks. So again, there was a variety of generally very limited assurance around competency of staff, varying from clinical competence to actually competence of delivering management capabilities. So again, looking at frameworking, looking at internal, external benchmarking. Is peer review in place? Is there any sort of direct observation? So again, the theme from the benchmarking came out that this was something that wasn't in place across a lot of these organisations. And ultimately, audit processes. So not having any sort of formalised audit in place that would assure the effectiveness not only of the systems that you've got in place, but particularly the clinical outcomes of them being effective for what you're trying to deliver. So the benefits from these services, that when we've had conversations with them, what they've seen is actually the benchmarking assessments have highlighted some unknown or hidden gaps. We've had some organisations where there's been waiting lists that are held completely independently from trust level, and therefore they've been hidden maybe from view and from where they can be easily identified and actioned. So it can sort of pull out some of these key things, not to sort of cause problems, but obviously to be able to again raise the concerns and the highlight for staff. It's allowed staff to hopefully openly express their thoughts and feel confident in being able to sort of come back with what are their challenges, what do they feel can be done better, what has been a problem for them. And ultimately, as with any UKAS accreditation assessment, it allows that independent view of service delivery. So it's people coming from outside of the organisation, coming in and taking the service at face value, using that evidence base of what you've got. Is it there? Is it working? Is it effective? One of the adages we always say is if it's not written down, it doesn't happen. So again, that documentation, the quality management system, are things written down so that you can be confident that if you actually had to go to a court of law or be litigated, you would have the evidence to support that actually, confidently staff should be following the right processes, the right procedures. It gives confidence to management, external stakeholders, ICBs of the fitness of the current service delivery. So if services are struggling and they need support, benchmarking is really sort of helping to identify those key areas where they may need some extra provision, and actually if the support's there to develop the service, is it the best pathway that's in place at the moment? Because we all know, I'm sure there's some historic pathways and historic ways of working that have been accepted and maybe not the best way forward for you. So again, looking at trying to make improvements and making sure that the service is fit to be delivered for successful and safe outcomes. Certainly enabled engagement from more strategic management and increased the profile of the service. I mean, I'm sure the profiles of most of your services are fairly high at the moment. But again, it allows for those services that we've worked with, the CEOs and the directorate managers to really have a view of what's been happening and what's going on in these services and key criteria that they need to action and work on to provide that support. And also hopefully then ultimately provided the service with dedicated resource and time to work on quality improvement. So this is one of the biggest things. We totally recognise that the resources are short in organisations just to even meet your clinical capacity. So therefore actually having dedicated time, dedicated quality managers or people who can actually put the time in to deliver a quality improvement and making sure that your service are meeting standards is a real challenge. And actually that has to have buy-in from the higher organisation to support that, whether that's at a local level or whether that can be supported a little bit more strategically across different disciplines in the trust. But that has highlighted that these benchmarking assessments have highlighted the need for the time to put into this, because those services who are currently accredited, and I'm sure some of you may well be on this call, you know, it's a hard job to do, to get accredited, but actually to be stable in that and have that stability, time is needed to allow you to be supported to do that. And ultimately that is the benefit and the importance of looking forward to getting accreditation, is you don't know what you don't know. So by having accreditation, by ensuring that your systems are working effectively and having that independent review, it means that hopefully you're going to be much more proactive in your risk management. Your systems will be working effectively. You'll be making cost savings and efficiencies longer term. And you've got then some real ammo to be able to support your developments and any business cases later on. So what can be done immediately sort of for yourselves? Think about the high risks that these assessments have already sort of encompassed and developed. So when we think about organisations that have maybe an audit team or a governance team or clinical effectiveness team in a trust or in your organisation, think about documenting your audit processes if it's different or if you're not using an organisational approach. Approach the clinical effectiveness team, get them to come and work with you and talk through an audit program. You know, what does that look like for you? Certainly, you know, audit programs are about auditing your service and your systems, and they need to be beneficial to you. You need to have outcomes from audits that actually you can react to and will make a difference to your service and your delivery. Think about effective management of waiting times. I'm sure you know that's high priority. Your key performance indicators. Are you looking at where you've got long waits at the moment? Are harm reviews being done? Are you looking at those long waiters? Are they being prioritised? Just because they've waited, they weren't maybe a priority in the first instance. If you're talking 6 months, 9 months down the line, have they been reviewed again to make sure that they haven't actually become a higher priority because they've had to wait? So it's systems like that, thinking about waiting time management, thinking about those indicators. Have regular monitoring around capacity and demand. You know, is there sufficient staff? I mean, I know at the moment it is a massive challenge, but are there things that can be done to enhance capacity? I'm sure everyone's looking at, you know, very seriously at the moment, but it's not always just about cutting times to get more appointments in, because again, are you then potentially compromising quality? It's thinking around what capacity do you need to meet the demand, and if you do start cutting your appointment times, you know, are you evaluating that to make sure that the quality of what you're delivering is still effective and still the same? And actually, if you do cut back on those waiting time, those appointment times, then that's not then going to be visible in your capacity moving forward, that you might need more staff, and is it compromising that quality of care potentially? And then ensure that there's a defined organisational structure, roles and responsibilities for authority, making sure that you've actually documented who is responsible for what. It's very much difficult to take everything on yourself. If you're a leader of an organisation, or if you're clinical leads, it's important to have the people around you involved in all this. And I would say certainly from an accreditation perspective, getting everyone in your service involved, from even just the bare minimal tasks of just checking, monitoring, check sheets. I remember when I went through the process, we had some of our Band 2s just reading policies and procedures or looking at them to make sure that they were in date and that they've got the right document control. So getting everyone involved, because they can then start to see how quality improvement affects them and how it benefits them moving forward through the accreditation process. You can develop, if you haven't already, look at documented processes and pathways. Are they consistent in your service delivery? Do they match any national standard, national guidance where that's appropriate? Look at other accredited services. If you're not on an accredited service already, I'm sure many of them will be willing to share documentation, share their approaches. If you have training needs analysis, make sure that, you know, that's adequate and you've got funds to support that, or that you can at least look at ways of delivering that training that can enable staff to develop and maintain their competence. Look at competence processes. Have you got an embedded framework of competence that might involve some direct observation, some peer review? It might be something that you're looking at across the physiological science networks, at your regional heads of service. Can you share and do some peer review between organisations? What might that look like? Think about how are you assuring that your staff are doing what you think they're doing to give you the confidence and the evidence that actually they're following the processes effectively. Looking at incident reporting, most people will have a formalised incident reporting processes in place, but thinking a little bit more about those low-level non-conformities that happen that we just manage on a day-to-day basis. Those are things that can become much more pro-risk management. You can be more proactive in the fact that if you're logging some of those lower level non-conformities, you can manage those before they become more serious incidents. Looking at equipment logs, are they in place? Have you got fault management processes in place? Are your equipment and facilities fit for purpose? And make sure, particularly for obviously audiology, looking at evidence to support the use of verification of hearing aid fitting, outcome measures. So a lot of the things that we're seeing are lack of consistent approaches to those being implemented. And those outcome measures, are they being used as they should do? Are individual management plans being provided for every patient at every appointment where it's appropriate to check their progress and ensure their goals are being met? So, lots of things to sort of consider before, you even decide to dive in. If you do identify any significant gaps, again, as I say, consider the themes. On the UKAS website, we have got on the IQIPS page, there's a readiness tool that you can actually go into, and you can answer questions that will support how ready are you to meet the IQIPS standard itself. What I would say is don't use that as a tool to say we've got to be green before we apply to UKAS. It's just a tool to give you a little bit of insight as to where are you and what development you might need. There's also a gap analysis form on there that you can fill in and look at where are you at the moment, what documents have you got, what implementation evidence and effectiveness evidence have you got. But make sure that you do look at national and professional guidance. So again, we've got the BAA paediatric quality standards, BSA recommended procedures as NICE guidance, the Chicago classification in GI physiology. So make sure that if there's any sort of national guidance that you are actually up to date, or that your policies procedures reference the most up to date ones, and where you are able to audit against some of these practices, that you are able to do so. Consider contacting accredited services to discuss, as we say, sharing documentation, processes, how to help you prepare. But actually, come and talk to us. We're really open, waiting. We've got capacity and ability to start our conversations, have more conversations with you. We've had, out of I think around about the 140 organisations that have got paediatric audiology services, we've probably still got about 50 to 60 that haven't engaged with UKAS at all, had no conversations. So this is why we want to encourage you to at least come and talk to us. Send me an email, ask for any sort of estimates. If you want to have a face-to-face conversation, we'd love to talk to you about what we can offer, how we can help support you, and if you've got queries, concerns, very happy to talk through those with you, because sometimes there's ways of working around those. So really, the options for you to start your journey towards accreditation is that contact stage. Either just go for it, get an application in, and we can start you moving, or have a conversation with me about what it is that you want to move forward with, what your barriers might be. You can then start thinking about, if you get on board with us, whether you want a benchmarking assessment, what type of approach you would like with that, so that we can then, as I say, support you on your journey moving forward. The training support that we offer within UKAS, we have got an IQIPS standard awareness course. That's on our training page at UKAS. That's something that we deliver mainly virtually. We have got one face-to-face 2-day course, and that's basically trying to give you the information and the tools by using actual assessments that we've been on, some sort of evidence going through that way of how to meet the standard for a lot of the core areas of the standard. And for those of you who might be interested in being a technical assessor for UKAS, we'd really value more technical resource. So do look at applying, because it can benefit your organisation if you've got the insight of being a technical assessor. You need to have had at least 4 years post-training experience, ideally had some management experience in the roles that you're in, but you can come forward for technical assessing in your areas of competence, and we have a process to sort of guide you through that. So again, do talk to me about that if that's of interest. We also have e-learning modules that are available for you, on-demand e-learning around internal audit, the UKAS process, uncertainty of measurement. So there's lots of different elements of e-learning that you can have a look at. There's non-conforming work, and talking about assisted application. So later this year, we're looking at, for any new applicants, hopefully having some e-learning modules and support webinars and materials that will be readily available, so that becomes part of your application package. And that again will give you that more support, more guidance alongside your allocated assessment manager once you've made an application to us. And as I briefly mentioned, the application readiness tool is available. So that's in a nutshell. I've spent obviously sort of half an hour hopefully going through the UKAS process of predominantly focusing on the benchmarking, because we really do want to start getting organisations to just start talking to us, get on board, and help support you on your journey. So I'm very happy to hand back to Laura and see if we've had any questions in the chat and take it from there. So thank you.
Thank you, Laura. Thanks for giving I know you're struggling with your voice today, so do appreciate you giving such a comprehensive overview. That was really helpful. We've actually not had any questions in the Q&A, so we've still got a minute or two if anyone.
That's fine. That either means I was very, very clear, or I flummoxed everybody.
I'm fairly sure you've just covered everything. As I say, we will leave a minute or two for people to add anything should they feel the need. Laura also did provide her email in a previous slide, which is laura.booth@ukas.com. And as she says, one of the first things is really just to reach out and get in touch, so we can start the engagement and see how we can help you along this journey. We do have information on the website as well, but yes, first point of contact is always to get in touch with UKAS.
If anyone does have a question and they want to raise their hand and unmute, if they'd rather speak it than write it, then I think we possibly have that ability to do so. Because I know sometimes it's not easy to write what you want to ask, so very happy to answer that way. But like I say, either I've stunned everyone into silence.
Yeah, I can't see anything in the chat or in the Q&A at the moment. So
Stephanie just put something in quickly. Is this process going to be implemented for agency type provision who offer audiology stuff? I'm trying to think. So are you thinking of locum staff, Stephanie, or are you thinking of like independent providers who offer? I think, are you talking about the agencies themselves who provide the audiology staff? We might need to unmute Stephanie, sorry. Independent providers, sorry, yes. So we have already the IQIPS standard isn't discriminatory to independent or NHS providers. What we accredit and offer accreditation for is the activity. So it's like pure tone audiometry or relay measurement. That's the activity, regardless of whether it's private or NHS. So the way we do that is where we've got services that might deliver both, or when we are doing an assessment, we will ask if they do any private practice, and we'll make sure that we are assessing the processes they have in place around independent practice as well as the NHS practice. So yes, from that perspective, this is available, the standard is available for any sort of independent providers. If you think about locum staff or locum agencies, that's a different kettle of fish, because that's a different organisation. That would just be they're providing the staff to you. It would be down to you as an organisation to make sure if you were using agency staff that you involved them in your competency process. So there would be an expectation that your competency documentation would include how you induct locums and how you assure they're competent to deliver what you want them to deliver. So hopefully that answered either of your queries. Thank you. So
we've
oh
had
bless, someone
something
said
from
it's
Karen
scary.
Dyer.
Louisa
Yes.
said it's scary, and I don't disagree. It's very overwhelming. I think that's the thing. What I would try and say is that actually for an organisation, a lot of the standard is very generic, and you will already have things in place. So if you look at everything but the clinical domain, your incident reporting processes, patient information, facilities, all of that, you'll have trust or organisational policies already in place. So actually from a policies and a procedures and a management system perspective, you've probably got a lot more information than you realise. I think the challenge comes where it's that demonstrate that you're doing it. So that's where some of this time comes. And I think this is where having either a management system, a bespoke management system, some of you may have heard of QPulse and things like that, that can be helpful, but having a dedicated quality manager or having someone who has that time to be able to evidence against those processes, that's where the challenge can sometimes come. So I think you're not wrong, it is a challenge, it is quite scary, but actually it doesn't need to be, and that's where I'd say please talk to us, because I think after talking to us, hopefully, I'm not saying there's less work, but hopefully it becomes a less scary process. Karen said lots of work, the trust is purchasing a QMS. Yeah, no, that sounds good. Useful to see the areas you don't have documentation. Yeah, I think the quality management system, people often get confused about, well, what is that? What do I need to have? And actually, most of you already have a quality management system, because it'll be your trust policies and procedures, and it'll be your local shared drive or whatever it is where you keep your documentation and your quality processes. So that is your quality management system. It's just about how effective is that, how can staff access that at all locations? Have you got the evidence to show that actually the staff are following then those policies and procedures and processes? So again, it's almost like that assurance side of things that need to be evidence, that is the work that needs to go into it. And then obviously the clinical side, hopefully, for most services, you'll have clinical SOPs and things like that. Some of them may need to be tweaked and slightly more robust and things like that. And then, Maureen, if you have a large service. Oh, sorry.
Yeah, we've had a question from Maureen regarding if you've got a large service, can you have only one sort of like aspect accredited? And she's given the example of NHSP preschool assessments.
Preschool assessments. Yeah, so you can have accreditation for whatever activity you wish to come forward for accreditation. So you could just decide to come forward for, let's say, visual reinforcement audiometry and ABR, and that might be all that you want to come forward with. We would question why you would only want to come forward with that, because actually, if you deliver all paediatric activity, there's no reason your management system and your competency processes and everything will still need to be the same across all of your activity, so that it almost seems pointless in such a minimal element of coming through. But that's not to say that we can't do it, and we have got some organisations where actually they only deliver, I think, the diagnostic ABR work, and then predominantly they're an adult service, so they've got adult activity and then they've just got their limited paediatric scope. We can also offer accreditation only for one location to start with. So if you felt actually you delivered accreditation at several community locations, but you weren't in control of those and you didn't feel as comfortable in maybe the environmental conditions, and you just wanted to go forward with your main hospital location, then again, you can do that, and that gets you started on the journey. And you can always bring on more locations or more activity as extensions to scope once you've got yourself accredited. So yeah.
Okay.
Answers that one.
Somebody else has asked, they've said, when looking at domains, I did find some of the domains overlap. Would you or can you reproduce the same evidence?
Yeah, so I acknowledge, I think there are some things in the standard that are a little bit duplicated. With it, certainly, we know that consent's in there a couple of times, calibration, facilities, things like that. So definitely, yes, the same evidence can be provided and would be expected to be seen. And again, we'd question if you're trying to do different evidence. We don't want you to be developing things to meet the IQIPS standard. In theory, the IQIPS standard is generic, and it's asking the questions of you as an organisation. What is it that you do and you deliver that meets the standard requirement. Sometimes that does mean that you do have to develop a process to meet the standard because it actually isn't there. But generally, we would say that your processes should be one and the same for the organisation. But yes, you can use similar or the same evidence. That's fine.
Super. For everyone's benefit, my colleague Pablo has just dropped in some contact details regarding the UKAS Training Academy as well. We do provide some training in this area, so he's put an email and a website there. We've also had a couple of questions about average times and costs. So they've said they do appreciate that it depends on any gaps that exist, but it would be good to know an average time for gaining accreditation.
So I would say the average time on all the services that we've currently got accredited, the average time from application to grant of accreditation is about 16 months at the moment. It originally was about 21 months and it has come down because I think people are just starting to get more engaged and a bit more understanding. So it's not a quick, certainly isn't a quick process. The quickest you could get through is probably, I would say, 6 months. But that would mean you'd have to be pretty much ready to rock and roll once you've applied. We'd have to be setting assessment dates, you know, for the next month, because actually the process of accreditation, when you've had an assessment, you have a 3-month period to close out any sort of actions that are raised from the assessment. So you've automatically got a 3-month window where the evidence is needing to be reviewed. And then that's subject to that being cleared the first time and being granted. So 6 months would probably be the quickest, but I would say 16 months is on average.
Sure.
From initial contacts application,
yeah. Sorry, we've had another question. Do we have an idea, a ballpark figure of approximate total costs for a small community site?
Yeah, it's costs are a funny thing because it depends on the activity and the number of locations. So for just a small community site compared to a hospital trust, if you're still delivering the same activity, it's based on the effort that we're seeing. So it could be a similar amount, but I would say probably one location for, let's just say, paediatric activity, you're still probably going to be looking at an initial assessment of around about 10,000 for that initial assessment costs. So it's still, the more activity you add on, it doesn't exponentially double the costs, if that makes sense. The more activity, the more locations, it sort of reduces the overall costs longer term. So it's more sensible, going back to that idea about could we just come on with maybe one activity, it's more sensible to bring as much activity on as is reasonable, because actually we only need another assessor for a day. When we're going to be on site, we're looking at the management system is the same regardless of whether it's adults, paediatrics or whatever. So the cost of any extra cost is just in the technical effort that we need to sort of imply.
Okay. I hope I've understood this question correctly. But do you recommend that an organisation completes the gap analysis? So they've then sort of gone on to say, we feel we are ready or close to ready evidence-wise prior to benchmarking, or should we just go for it, basically?
Yeah, the gap analysis is there very much for your benefit, but actually also if you feel it's useful, it can be helpful for the assessment manager that gets assigned to you, because they can work with you on, you know, if there are any key gaps, what is it that they can help advise you with to sort of help support that to have a successful initial assessment. However, I would say actually, if you're thinking about coming forward and having a benchmarking, it's almost going to do that for you. So depending on where you think you are, if you feel you're ready to actually go forward for accreditation itself to the standard as it is, we also offer the normal route for accreditation would be application, and then we'd offer a pre-assessment, which is slightly higher level than the benchmarking. The benchmarking, we go into much more depth of looking at the content and details of your processes. The pre-assessment is slightly more looking at the standard, what processes have you got in place, making sure you've got the documentation, but we're not really going into massive depth around that. And then we are just looking at a little bit of activity and probably doing a little deep dive into some of the core areas for pre-assessment. And that again, probably costs wise can be anything, depending on what you want, anything from 3,000 to 8,000 for that pre-assessment, which is slightly different to the benchmarking. So it's really up to you, you know, really which route you want to go down, and if you feel a gap analysis is useful for you.
Okay, I'm going to read this one out because I'm not sure. I think it'd be better for you to interpret it. So, when deciding about community locations, is it that any aspect of provision should be accredited, e.g. repair clinics with no assessments, or should it just be assessment fitting clinics?
Okay. I think if I'm interpreting that correctly, so there is a list of activities that we have what we call technical competence criteria for. So when someone becomes a technical assessor for UKAS, they have to define what are they technically competent to assess. We've just redone those actually recently. So one of those technical competence criteria is like hearing assessment, but within that hearing assessment, it covers otoscopy, history taking, pure tone audiometry, possibly impression taking. So the whole point of a hearing assessment, and we would want that would go on a schedule of accreditation. So if you were coming forward for your community locations, it's likely that if generally adults or paediatric audiology that's delivered there, you would want to come forward for the paediatric assessment and paediatric rehab and adult assessment and adult rehab. And then we've got wider technical skills. So we've got skills set like tinnitus counselling, TFI. We've got vestibular, VEMPs, VHIT. We've got bone anchored hearing aid assessment and fitting, cochlear implant fitting and mapping and assessment. And then we've got complex adult. So we've pulled everything into a complex adult assessment, sort of with learning needs, so adults with specific needs, assessment and rehab. So we would expect a service, if they were going to deliver that they have a proper pathway and proper training and processes in place for adults with learning sort of needs. But it's unlikely you'd deliver that in a community location. So I think probably for community locations, you're likely to have just hearing assessment, and within that there is hearing rehabilitation, and there's also repairs is sort of in that hearing aid adjustments, and repairs is within that scope. And that would be defined, it would have hearing assessment, but it would actually define the core activity within that as well for you on your schedule, so that it's very clear that you've got otoscopy and history taking and PTA and everything accredited. So I'm hoping that answered your question, Stephanie.
Thank you, Nora. We've also had a question come into the Q&A. So this person works in GI physiology as a single practitioner. Can they still apply? And they also say, would you apply for all physiological services in one go rather than different disciplines at different times?
Oh, good question. It's always it depends. It's the UKAS stock answer. It depends. So yeah, if you're a single practitioner in GI physiology, yes, you definitely can still apply. And we have had an organisation that's got a GI service that was accredited. They have been accredited. They are a one person, one band, and they've worked out, I suppose, the key areas when you're a one person delivery is how do you assure your own competence and the practices that you deliver. And there are ways of doing that. You can get external, people coming in to observe you, and there's different ways of doing it. The one that we've got, as I say, that was a sole practitioner was part of a larger organisation that came forward with other disciplines. So that actually was more helpful for the lone single practitioner, because actually the quality manual and the processes and the documentation and how it was assessed was assessed as a sort of whole across all of the different ologies. So the GI physiologist is then sort of supported more with the other disciplines alongside them. So yes, definitely still think about applying if you're thinking of applying singly, as a sole practitioner, but you may find that if you can get other services on board with your organisation, that you will be more supported and find it a lot easier, because otherwise it's just you having to do everything. And I think, my audiology colleagues will already say how challenging it is when they've got more than one person in their organisation. So just you trying to work on it would be a really big challenge, but it wouldn't be something that was unachievable if you have the resources. Hopefully that answers that for you, Stephanie.
I think it did. And we have reached the end of our questions now. We don't have any other questions in the Q&A, or I don't believe, just double checking, I don't think, nothing else in chat either. So thank you very much. Thank you to everybody who's taken time on their lunch hour to join us today. please do forward any questions to us if you've got anything that hasn't been answered today. And Laura, thank you very, very much for talking non-stop for an hour with a sore throat.
That's okay. I think we probably can email this out to people if they would like it. So
yeah, that's fine. I can organise that. That'll probably happen next week. Okay, super.
Lovely.
I'll
Thank you,
close
everyone.
it there then. Thank you very much.